fantastic presentations by our panelists. And I know we have a clinician on our panel, so I'm a little bit surprised that meaningful use didn't get mentioned as a disruptive innovation here in healthcare. But anyway, I believe we have about 15 minutes for Q&A session. And after the presentation, and it's time for lunch, but you're more than welcome to come up and mingle and ask additional questions if you want to. As our audience preparing for your questions, if I may, I would like to start a question for you, Eric, since you touched upon on total cost of care. And we know that disruptive innovation in healthcare is aimed at not only to improve quality of care, but also to bend cost curve. So my question for you, Eric, is in your organization, what are some of the key strategies that you have put in place to help your key stakeholders to get engaged, to understand, and to manage cost of care? Or maybe for the other two speakers is, how can disruptive innovation in healthcare can drive down cost even more?
Yeah, great question. So it's going to take more than just one party looking at how to engage the patient, how to engage the provider, and how to engage the health plan and the employer all together. So we have incentives in place for each of those pieces to work to engage and to bring down the total cost of care and also to improve the quality. There's incentives to the providers that they have certain quality measures that if they meet, that they get an additional incentive or bonus. There's also incentive if they bend the cost curve through the benefit design with the employers. So if you are a member or a patient and you see one of the total cost of care providers, then you have a better benefit. So there's a lot of strategies that we've deployed to engage everybody in that process. But the real power is that common care plan that brings the clinicians within the health plan to the clinicians that are on the ground seeing the patient and treating the patient and coming up together what's the best treatment protocol to engage with that patient or that member.
Mm-hmm. Any additional?
Sure. Sorry.
Any additional thoughts from Dr. Sobko and Todd?
I personally think that the way we're able to reimburse for some of our time has really grown tremendously. So, 3 years ago we had one billing code you could spend for patients with chronic conditions more than one. So if you had 2 or more chronic conditions, you could spend 20 minutes per month on the phone doing telehealth or providing services for your patient. You could bill for that time. Well, it's up to 90 minutes now. So that's meaningful and significant. And we now have more than 19 different codes that we can bill for our time. So when you're using technologies and you're trying, whether it's telehealth or telemedicine, or you're just providing, phone support for a patient at a distance, now there's a reimbursement model that provides value for the provider to take advantage of that. And it's really, really great for patients who live 40 or 50 miles or more away from the healthcare center, or who need transportation problems, or who need some triage support before it becomes an imminent crisis and they end up in the emergency department. If you can do an early intervention by brainstorming and finding out what's going on with the patient, you've done remarkable things to reduce the costs of what it actually costs it to take care of that patient. So I think using technology to augment the in-person visits and being able to bill for that is really, really of tremendous value.
Mm-hmm.
I'm trying to remember the specifics of the question. But when I think about innovation in healthcare, there's some other models in different companies that work pretty well. Procter & Gamble has a program that they created called Living It and Working It. And Living It, an employee of Procter & Gamble who's trained in ethnography will actually come live in your home with you. They'll pay you to do this. And they will do your floors with you. They'll do laundry with you. They'll do windows with you, dishes with you, because they want to understand the job you're trying to get done. And they did this in Mexico back in the early 2000s because their product was failing. And so they sent a team there to go live with the mothers who predominantly did laundry in that area. And out of that product, long story short, is that they created Downy 2-in-1. And so today, if you use a 2-in-1 shampoo and conditioner or Downy 2-in-1 or anything that's a 2-in-1, you can thank ethnographers who went to Mexico to live with people who are doing laundry. And my only point about that is if it's important enough to do it for laundry and soap and other things, I think the real way to understand how we need to innovate in healthcare is going to be in the same framework. We need to go where people live, work, learn, pray, and play. And if we do that, then we'll innovate much more effectively. The failures will not be 90% maybe they'll be 85%. And it'll just get us to where we need to be much sooner and better.
Great, great. Any questions from the audience? Yes, the gentleman behind.
So this is for Heather. So with the patient engagement platforms, what kind of impacts have been measured around patient satisfaction, around clinical improvement, and around reduction in utilization, or half of them?
So we measure patient-reported outcomes as part of that strategy. So we really want to know, what did the patients think about it? I can give you an example that when first trying the interactive voice response system, the phone was selected because it's inexpensive, requires no special training, and everybody's got one. So we didn't want to do a web-based intervention because all of our rural and elder patients would be disqualified from that in great numbers. So we picked something super easy, very, very simple, intuitive. The voice of the phone is a real person's voice. It's not a Siri voice. We actually hired professional talent to sound like a nurse, calling the patient and checking on them. So the system would automatically triage, ask patient relevant questions about their specific health needs, and then automatically triage them based on patient responses. Patients who are doing well don't need a follow-up call. Patients who are having issues or red flags need some intervention. And so a real person would call the patient and talk with them about the situation. So initially, to test this out, I enrolled 586 patients, and they all were asked to respond to 30 different phone calls throughout a 30, 45-day time period. 86% response rate. 86% of those individuals responded to every single call. That's very, very unusual. And it's because there's a big burden there, but I wanted to know, what do they think? So they like the voice of the system. They were also given the opportunity anytime, 24/7, when is the best time for you to have a chat with someone who's checking up on your health? And it could be anything from 5 in the morning to 11 o'clock at night. Since a system was generating the call, it didn't matter to us when the patient wanted to have the call. So that was very meaningful for the patients as well. It's just a little tiny component of giving patients choice, and they like that. But I think the most telling thing is that after some patients completed the entire testing period, I often got phone calls asking what's wrong with Kathy didn't call me today. What's going on? I think my system's broken, and it's, you finished the program. So that's meaningful when the patient, so it's just a technology, it's a voice recorded questionnaire that gathers meaningful information from patients, but they like it. And so they use it. And patients who are engaged, as we know from the work of Coleman and colleagues out of Colorado, but patients who are engaged have better outcomes. And it doesn't matter what their prognosis is, end-stage cancer, doesn't matter. If the patient is engaged, they do better. So I think that speaks volumes about those types of technologies. Did that answer your question?
I didn't hear any results.
Oh, results. So we had a 27% reduction in hospital readmissions and a 31% reduction among those that were tested in emergency department utilization. So I think but I did not do economic analysis. We did quick, rapid iterations and kept spitting out something new and trying to get it ready for for the real launch. And but I think that that's significant with regard to savings. And then, you know, so the patients who are not going to the ED are also not getting hospital-acquired infections, and they're, you know, not going through the stress or potential risk for fall and other things that can happen when they're in our environment.
Yeah, this gives me some thoughts for a follow-up question, because I feel healthcare needs to embrace consumerism, right? And we need to be more patient-centric or consumer-centric. So just to piggyback off his question is, what can we do more to engage consumer utilizing our disruptive innovation?
Was that a question for me?
For all of you
for all.
guys, yeah.
Want to take a stab at it?
I still think about this pretty simply. When we're thinking about technologies and people, I still believe we're making an incredible amount of assumptions about what people do. And I think we still are doing a lot of this in conference rooms and in conference calls and in our cubes. And so I think if we really want to understand and make things stick, we need to get into understanding how people behave. And what they say and what they do is not what they say they do. And it's not because people want to give you incorrect facts. The brain's just not built that way. We just can't tell you in enough detail to design something that would delight us. And so I think we need to get more into their world, because traditionally healthcare has required people come to us. And I think innovation is a collaborative team sport. And if we put patients on the team, Stanford has a wonderful program called Patient in Residence, where their patients will actually come work as a volunteer for a year in the system and go do observations along with clinical teams and ethnographers and designers. So, I mean, this could be a very long conversation, but I think we need to do a much better job of understanding reality versus what we believe people are doing. Then we'll design better.
Yeah, Eric.
Apparently I wasn't talking loud enough, so let me take this off and speak right into it. So I think we really need to look at what is convenient for the person that's consuming healthcare, not what is convenient for us as providers or clinicians or elsewhere, but what's convenient for the person. I mean, we are all on a cell phone and a smartphone most of our day, right? Not just because we're in healthcare, but consumers. We all have one of these. So how can we use technology to engage and connect with the person? Some people like to have that face-to-face. Some people prefer to have a conversation in a text, or some people like other type of interaction. So it's really finding what is important to the consumer and thinking like the consumer to find the solutions that will solve their pain points in the way that they want them to be solved, and not the way that we think that we should solve it for them. And I also think that until there's a little bit more financial incentive that's put onto the consumer to have ownership and responsibility for the outcome of their own health, we have a culture within healthcare where we look to the clinician or to the hospital to solve things for me, rather than me taking ownership for my own health and my own responsibility for my own outcome. So we need to get to a point where there's incentives financially and make it convenient.
Great. Yes.
We talked a little about what's going to be in the future. Unfortunately, in healthcare, we can't just cut over and say this is a great idea. We have an existing basis we have to keep in place. And so as we layer on the additional cost of the innovation, whether it's disruptive or planned, how do we look at an economic model that keeps the system intact while we make the transition?
I'll take that one. So you have to do.
Eric, if you wouldn't mind,
Oh,
just
sorry.
repeat the question.
Repeat the question. So the question was, how can we have the investment currently that we have in the system today, but also to make those innovations that are very costly? How do we do both at the same time is essentially your question. So in my mind, you have to do both at the same time. You have to be under the current system, the way it works today, but you also have to have those experiments. You have to try different things and figure out what works, and have the courage to have the financial background behind you to say, we're going to fail sometimes, and that's okay, because there's learning within that failure. And then you retool and you repurpose and you re-engineer your system and the way that you're trying to engage with patients or other ways that you're trying to be disruptive, you just retool it. So I think that you have to have that investment while having the chassis of the fee-for-service today. It is all changing. And CMS is a leader in that, where they're trying to go, reimburse providers differently today. So commercial plans can also engage providers in the same way to say, we're going to tap into some of those other programs that are in place and replicate them. So there's lots of ways that you can do that.
So I think that the ideal is to move away from what we've come to know as tradition. So I've been an entrepreneur and I've also been in an academic setting, and I know exactly how hard it is to take ideas to academia and have it first. We move like dinosaurs. We're very, very behind the curve. It's just the nature of the bureaucracy and how the size of things, I think. So finding alternative strategies for funding and collaboration is critically important. So it can't be just one discipline. It really will take vendors working with research scientists, working with engineers, and we don't have very good rules that govern who owns what or who's responsible for what, and that's a barrier. But coming up with strategies that work for everyone, including the patient, and keeping the costs down is really the way to go. So sacrificing some of the profit in order to be collaborative and quicker and better at it is, in my opinion, a really good idea. It's not popular. It's not the traditional business model, but I think that's going to become the only way that we can be successful.
Let me just add one more caveat to that. It's not always financial. As we make these changes, we may have unintended consequences that compromise quality in our very best opportunity. If suddenly your outcomes go down by, instead of reducing ER visits, you reduce the ER visit, but the admissions were more costly, they had a greater degree of problem, everything else. Where does that liability land now if, through the innovation, we create an untoward outcome?
The most important piece of what you just mentioned with regard to quality going down and outcomes becoming more poor is that the technology is a tool. It is never intended to be and cannot be a replacement for human-to-human interaction. It cannot be. It's a tool for us to use and to use effectively to engage with patients. It cannot be a substitute, and it can't be thought of as a substitute, if that makes sense. So, and patients are okay with that. If it's, yeah.
The way we approach it through our total cost of care program is there's the first thing that the provider has to do is to have better outcomes and quality before they have a financial reward. If they don't meet those outcomes of reducing readmissions or if admissions go up, then they're not going to be financially rewarded. So you have to have both in the programs that you're trying to implement to affect that change. But yeah, so that's how we approach it.
I feel like we could have another 2 hours of conversations and discussions on this, but unfortunately our time is up. And thank you everyone for your participation and questions and comments. And let's give another round of applause for our panelists.